All right, welcome everybody. I'm Penny Gordon-Larson, and I am so pleased to introduce John Batsis, who is new faculty in the School of Medicine and Geriatric Medicine and in nutrition at the Gillings School. And John has, he's one of those doctors. He has a medical degree from the University of Dublin, Trinity College in Ireland, and his residency training in internal medicine and fellowship in geriatrics from the Mayo Clinic College of Medicine in Rochester, Minnesota. And I've known John for many years, and when I heard that he was considering UNC, I was really very excited. He is a colleague of mine in the obesity world, and he has a very unique perspective on a number of aging related issues. And his experience as a clinician researcher means that he brings a very deep understanding of a range of research issues that really span research and practice, and is really critical to any work that addresses healthy aging. And he is primarily an NIH-funded researcher, and his work focuses on aging, but broadly includes obesity and physical function in older adults, as well as telemedicine and the use of technologies to improve health in older adults. And he also does some work related to rural health. And he has some really fabulous ideas about healthcare delivery and trajectories of health and function. And when I described CPC to John, he was all in and very excited about the range of work that we do here at CPC and in our collaborative population approaches, which appeal to him because he's very much of a team scientist. And I'm sure you'll enjoy his presentation, and I hope that you'll have the opportunity to meet him in person someday and collaborate with him. So a little housekeeping before he starts. If you guys have questions, you can use the Q&A during the talk. And if you prefer to ask your question yourself, you can just put your name in the Q&A and we'll call on you. And I have a hard stop right at 1, but John has graciously offered to stick around. And so he is happy to talk to folks for a bit after the presentation is done. So now I will hand the floor over to John and listen to what he has to say.
Okay, let me see if I can get this working here. Are you able to see my presentation? Yep. Great. So step 1 done. Thank you, Penny, for the very kind introduction. And I hope, as Penny noted, that I can meet everybody at some point in person. It's been an interesting transition, and certainly very welcome to be able to kind of share some of my work and some of what I find fascinating from an aging standpoint and obesity and muscle. As I shared with Penny, I'm putting my epi hat on. I have a good bit of work that I've done in the epi world, and looking forward to hopefully being able to collaborate with folks as I learn the landscape. So let me get this. Okay, so just funding and disclosures, none relevant to this presentation, but just full transparency here. So some of my learning objectives here are really to describe the epidemiology of an older population with obesity and how it impacts physical function and mortality. Importantly, to understand some of the changes that occur with body composition with aging, and again, how this relates to important relevant outcomes for older adults. And then I'll briefly touch upon, I do a good bit of intervention work as well, which won't be the focus of this presentation, but I'd be remiss not to share some of the early work some of the work that I've done on in this domain. So, as any geriatrician and geriatric care provider, I have to give my requisite older adult slide that our population is aging, and that in the United States in particular, over 20% of the population is set to be over the age of 65. And this is growing. This is the fastest population segment in the United States. And actually the old, those over the age of 85 are the fastest growing. And a lot of this has to do with changes in life expectancy because of improvements in cardiovascular health and cancer health. Why is this important? And this is important really because as one ages, the number of chronic conditions rises. And I bring to your attention that this is an older study, but it's a really relevant one, whereby they use the Medicare beneficiary survey, and then they categorize individuals by different age groups. And you can see that those over the age of 85, in the bars in the far right, have the largest number, the highest number of Medicare chronic conditions. This actually rises quite steeply with age. And as one develops chronic conditions and different medical comorbidities, if you live long enough, and this is a fun slide that I always like to show, if you live long enough, you will end up likely having a disability of some sort. When I define disability, it's really an impairment of one's basic activities of daily living. That's a talk for another day to kind of go through those details, but it's really about impairment in walking, bathing, dressing, toileting, feeding, and getting in and out of bed. So the more chronic conditions one has, the higher the risk of developing these disability. So I'm going to shift focus just briefly here, just to the issue and the public health epidemic of obesity. When I'm in circles in my primary care world, in my research world, and even in my geriatric circles, when people don't think about obesity in older adults, and I wanted to just lay the foundation for the group here. This is actually a problem not only in younger adults, but also in older adults, and it's unrecognized in many means in an older adult population. So very similarly to a younger population, and a younger adult population, you could see these are the most recent 2017 to 2018 estimates. 42% and 43% of men and women respectively are classified as having obesity over the age of 60, using a body mass index as a marker for obesity. This is using National Health and Nutrition Examination surveys. So it actually it is important in older adults, and it's very, very much prevalent. Now, I mentioned the importance of Medicare chronic conditions, and this is a study actually that looked at the relationship between multimorbidity, so the individuals who have two or more comorbidities, and the risk of obesity. And this is a study that demonstrated that both in males and females, the risk and the association of multimorbidity with obesity was high. So that in this study, the rates of obesity were about 45% in those over the age of 65, and there was almost a twofold higher association of multimorbidity in those with obesity. And that's not surprising, because obesity actually can impact a considerable number of chronic conditions. I mentioned life expectancy earlier on. Now, I'm going to take us in rewind a little bit. And when we think about life expectancy a couple of decades ago, individuals had a normal period of normal function. Then they had a period where they were subject to impairments and may have had a disability, and then they expired. In this day and age, that period of normal function has extended, and a lot of that has, as I shared, is due to improvements in cardiovascular and cancer health, and life expectancy has improved. But that individuals run the risk of having a longer period where they're subject to disability because they're living longer. And when you add the comorbidity, this risk of disability actually increases. So the so what question is really when we look at trends of obesity in individuals with disability. This is cross-sectional data, and I'll show you some longitudinal data in a few minutes, that the risk of functional impairment or mobility impairment, severe activities of daily living impairment, or moderate to severe activities of daily living impairment over the course of different NHANES surveys, it's consistent that individuals classified as having obesity are at higher risk of disability. So we know this is bad. This is not a good relationship to be in, and I'll show you some data in a bit that demonstrates the reasons why. So Early on in my research career, we had conducted a number of cross-sectional studies using NHANES data, and a lot of the data that is observed in the literature is classifying obesity using BMI, and I'll come back to that in a minute. But we actually looked at obesity classified using body fat, and that is important. And the reason here in this study, this was using older NHANES 3 data, but you can see that when we categorize individuals based on body fat, and body fat both in males and females, that those in the highest tertile of body fat actually had the highest odds ratio of having a disability based on activities of daily living in NHANES study. The figure to the right is another interesting study conducted by a colleague of mine at Wake Forest. She looked at the health ABC study, which is a longitudinal cohort study, and they were able to look at the degree of how long someone was classified as being overweight, or how long someone was classified as having obesity. And what their data demonstrated that the longer the duration of being classified as being overweight, and it was worse in individuals classified with a longer duration of obesity, there was a higher risk of incident disability. And so from a life course standpoint, duration of being classified as being overweight or having obesity is really important. This is another study. This was a meta-analysis of 26 studies. Range of follow-up was between 1 and 13 years, but in older adults. And it really demonstrated consistently that a body mass index of over 30 was associated with a 60% higher risk of incident functional decline. This study looked at the burden of disability, again, looking at individuals with obesity from a life course standpoint. So they looked at using the Framingham and the Framingham offspring heart study, and they found that individuals with obesity in early age, so 30 to 49, and then they followed them going forward, that they actually had fewer years of life that they lived without a disability. So again, this really provides additional evidence to suggest the importance from a life course standpoint that we need to be treating these individuals early on, otherwise they'll have increased risk of disability and impairment downstream. This is, again, another study that looked at midlife obesity and subsequent physical disability. Their analysis was really interesting because they actually looked at the duration of each year of obesity with the relation of disability. And they found for each year in a normal and in midlife that there was a 3% higher risk of increased risk of disability for every year of obesity. When they looked at 10 obese years and the risk of disability, that risk was about 8%. So again, it's not only important to be able to address individuals with obesity in older adulthood, but when you take a step back and look from a life course, this is really important information that I essentially provide to my younger patients, from that the duration of obesity is really important in terms of being able to be physically functional in older adulthood. This was a study that, again, another prospective study. They looked at individuals at mean age of 52. They classified individuals as being healthy agers, successful agers. What does that mean? Were they free of 9 different diseases, depression, and without any physical or cognitive impairment? This is important because we know that the risk of depression, the risk of physical impairment, the risk of cognitive impairment actually increases with age. They looked at 5 important factors: smoking, physical activity, alcohol use, and obesity. and social support. And what they found was that individuals with five of these factors had a fourfold risk of not having a degree of successful aging. Or put it the other way around, if they weren't smoking, if they were physically active, if they limited their alcohol intake, if they were not classified as having obesity, and if they had adequate social support, and each of these were defined differently, they had a fourfold higher chance of an association of being a successful ager. And that's what's really is kind of the utopia when you think about from an aging standpoint. Individuals want to successfully age. They want to not be subject to physical impairment or having a risk of disability downstream. I was fascinated by this study. When we think about the trajectory of impairment, we think about individuals with frailty or disability. Frailty is that you can be frail but not disabled. You can be frail or have a disability, but it's a Venn diagram. And I bring this the concept of frailty up because we talk about that considerably in the geriatrics world, because it's a physiological disturbance of one's homeostasis. This study actually was just published last month, and they actually, again, was a longitudinal cohort, and you can see the follow-up was quite impressive. And they actually demonstrated that for every year of an additional year of being classified as having obesity, there was a higher risk of frailty both in males and females. But importantly, if the trajectory of BMI increased during this period of time, so longitudinal measurements, and if it increased, you can see that in males and females, there was an 8-fold higher risk of incident frailty. That's nothing to sneeze about. That is really, it has a huge number of potential repercussions from a healthcare utilization standpoint. So I'm hoping I've proven here the importance of obesity from a life course standpoint, because it really does impact, if individuals have survived, to that this could lead to marked impairments of one's function. I'd be remiss as a geriatrician not to talk about anything about nursing home admission. And this is, again, a longitudinal study that looked at individuals in the Kaiser Permanente system. All these individuals were in their 50s, and then they looked at them again 25 plus years later. And what they found was that there's a 30% higher risk of nursing home admission in individuals with obesity. So even midlife obesity does predict increased risk of nursing home placement in such individuals. Sorry there. So just briefly, there's a wealth of data that demonstrates both in middle age and in individuals who are older adults. So I bring to your attention in the NHANES 1 follow-up study that they looked at actually individuals between the ages of 65 to 74. And even if you were classified as having obesity in this age group, there was still a significantly higher risk of nursing home admission. And these findings were also evaluated in both different types of data sources: minimum data set, which is a nursing home data set, and the Medicare current beneficiary survey. What I found was interesting that the probability of nursing long-term care admission. So if individuals were severely obese before death, these are individuals with class 2 obesity, BMI of over 35. There was over 50% higher a probability of a long-term care admission in these individuals. So again, something to think about when you think about the risk of obesity going forward. Now, this is where I find the discussion gets a little interesting. And as I've shared with you that the majority, I would say, of epi studies are focusing on using body mass index, BMI, as a marker for obesity. And when we think about population-based evaluation of obesity and mortality, we think about this traditional U-shaped curve, where individuals who are classified as having obesity or those who are underweight are on opposite ends of the spectrum. Now, this was an interesting study that actually looked at mortality in those over the age of 65. And it was a meta-analysis, as you can see, over 197,000 individuals, 12-year follow for death. And the U-shaped curve that is observed here is interesting in the sense that, excuse me, the nadir BMI is that in the overweight category, which really is somewhat counterintuitive to what we think about when we think about the category of overweight. Those individuals in many epidemiological studies actually have a marginally higher risk, and we traditionally think of those individuals in the normal BMI category as being the lower risk. And the inflection point at which mortality started increasing was at a BMI of over 33. Now, doing a deeper dive using some additional data, this is NHANES data and combined of a number of NHANES surveys and mortality follow-up, you can see these curves actually flatten with age. So the BMI mortality curve is actually pretty flat in those over the age of 85, and it flattens with every 5 to 10 year age category. So that's important to know. Why is that important? Well, before I jump into that, I would need to we need to talk a little bit about the obesity paradox. There are probably individuals on this webinar that believe in it. There are others that don't believe in it. But just by way of introduction, this is something that was raised in 2002, where a finding actually found that individuals with coronary artery disease with a normal BMI were unexpectedly at a higher risk of complications, death, and 1-year mortality. Now, there are various individuals that have demonstrated in different types of studies that having an elevated BMI may be protective from a mortality standpoint. I do caution the group, though, and there's a number of individuals that have written on this. Catherine Flegel and John Ioannidis in particular have really described there are a number of biases that impact this relationship. And I'm not going to read them, but here are some that are presented. They actually had a really nice editorial in Obesity a couple of years back. This was a study that came out a few years back, but 2 years ago, that pooled 10 large US cohort studies. And in my mind, this proved to me, with 3.2 million years of person follow-up, that individuals with obesity, classified as having obesity, both male and female, actually had higher risk of cardiovascular morbidity and mortality and overall death. And a number of reasons why this study was, in my mind, convinced it accounted for a number of these biases, but importantly, the length of follow-up was something that hadn't really been seen before. Another reason why this may be the case is this phenomenon of normal weight obesity. Early on, when I was a fellow in junior faculty, I had conducted a number of studies using different data sets, actually, both NHANES using the Osteoarthritis Initiative and using data from the Rochester Epidemiology Project, where we looked at individuals with a normal body mass index, but they actually had central adiposity. So elevated hip ratio, waist circumference, or body fat. And these individuals actually had a higher degree of cardiometabolic dysfunction, higher risk of mortality, and a higher risk of long-term disability. Why is this important? Because these are the individuals in the clinical realm where we look at a BMI and we say, oh, your BMI is fine. And that's a problem. That's fundamentally a problem because they actually may be at high risk for adverse events. So again, we took this one step further and we actually looked at the diagnostic accuracy of BMI in older adults. And this, in my mind, it was not because myself and my group published the study, but we really looked at older adults. These are older adults using NHANES data, and you can see the sensitivity of BMI as a cut point when you look at it in relation to body fat as the gold standard, had a poor sensitivity despite the high specificity, both in males and females. And I want to just let all of you know that this actually sensitivity drops precipitously with age. So when you look at the individuals with who are over the age of 80, the sensitivity of BMI in ascertaining body fat was actually just shy of 20%. So it's not a great marker for obesity, particularly in older adults. So just very quick summary here. Our population is aging, rates of obesity are rising. Obesity measured using BMI, we know with a number of studies, is really strongly associated with a number of these physical limitations, nursing home admissions, and death. But I caution in older adults, it shouldn't be the only anthropometric measure that should be used. And there are a number of reasons why. This is a cartoon that I like, and this really shapes the changes in fat and muscle that occur with age. And you can see that the 70-year-old, there's a redistribution of fat in the central areas. So higher degrees of central adiposity, and one loses muscle mass with age. And you can, this is the individual with adiposity, but actually has very little muscle mass. And just to introduce everybody to the additional changes that occur with aging, this is, again, a population, a composite of a number of population-based studies from the UK that looked at the changes in muscle strength with aging. And you can see that peak muscle strength is between 20 and 40 years in both males and females, and then it drops with age. So there is an age-associated drop in muscle strength with age. And so that is normal, and individuals have different trajectories as to whether or not what can influence that. But muscle mass is not entirely 100% correlated with muscle strength. And that is an unbelievably key element here. And in part, this issue of muscle mass and muscle strength plays into the whole BMI issue as well. So one ends up, this is a seminal study that demonstrated that muscle strength actually drops in advance of muscle mass. So in 3 years using Health ABC study, there were no changes in both men and women in lean mass. But you can see that muscle strength actually dropped. And this is by BMI category, that individuals with muscle strength actually, there was a change in muscle strength in a short period of time. That is critically important because not everybody that loses muscle mass will lose muscle strength. And much contrary to popular belief that if you lose muscle mass, you're losing muscle strength. So how about this? How about what happens in individuals with obesity? The Chianti study, again, a population-based study conducted in Italy, demonstrated the synergy of individuals who lose their strength and who have adiposity based on obesity. Those with low muscle strength and classified as having obesity, and this was different trajectories of different categories of obesity of individuals solely with low strength, solely with obesity, or those with neither low strength nor obesity. Those with low strength and who are classified as having obesity actually had the fastest decline in walking speed, which is a marker, gait, it's otherwise known as gait speed. It's a marker of physical function. And then the probability of mobility disability, is, as represented here in the panel to the right, is the highest. The rate is the highest. It's the highest probability of mobility disability in this subgroup. And this is, again, a longitudinal study of 33-year follow-up. And what I wanted to bring to your attention is that in the importance of individuals with a high muscle strength in obesity actually still have a higher risk of death as compared to their overweight or normal counterparts. So incorporating muscle strength as a measure of physical function and as a mortality measure in individuals with weight issues is critically important. And why is this the case? Well, panel on the right is an individual without obesity, but it has normal muscle. This is an image of an MRI image of one's thigh. And you can see in the panel on the right that there is elements of white segmentation within the muscle tissue. That is what we term fat infiltration in the muscle. And this fat infiltration leads to this crazy mechanism, which this is a review article that we had published a couple of years, 2 years ago, which unfortunately still gives me a little PTSD looking at it, but it highlights the inflammatory underlying mechanisms of the interaction between fat and muscle. By no means am I going to go through this today, but this is the phenomenon of what we term sarcopenic obesity. So we're familiar with the term obesity. Sarcopenia is the loss of muscle mass and or strength with aging. And infiltration of fat within the muscle leads to this pro-inflammatory cascade that is problematic and that ultimately leads to impairment of physical function. Now, before you start thinking about treatment or how to approach this, you need to think about the definition. And unfortunately, there is no standard definition for sarcopenic obesity. Even when we think about obesity, there's a variety of different modalities and measures. BMI, waist circumference, body fat, for instance. Sarcopenia has been defined in a wealth of different ways. And I'll come to that in a minute, but there's really no fully accepted consensus. What I can tell you, these are some modalities. DEXA, upper left, lower is, we can use either CT or MRI. This is a handheld dynamometer, which can easily measure muscle strength. And then you can have some fancier machines that can measure lower extremity strength. The European Association for the Study of Obesity is currently engaged in a consensus statement, which I'm privileged to be involved in, to be able to look at this very issue. How do you define this entity? And it's important to define this entity because only then can you really use this and apply these definitions to cohort studies and then subsequently be able to conduct intervention-based studies. So an earlier study that we had conducted was to look at the prevalence rate of different definitions of sarcopenic obesity, because the so what question comes up. Well, we know obesity is a problem. What about the sarcopenia bit? And what about, and you're telling me that the sum of both of these could be more problematic because we have challenges with both sarcopenia, challenges with obesity. So what about the two together? So fortunately, but unfortunately, this study was really helpful and unhelpful at the same time, in that we recognize that the rates of sarcopenic obesity actually increased with age, but the definitions were all over the place. We found an 18-fold difference in definitions of individuals with sarcopenic obesity, depending on the definition you used. And that's a problem, because when you have definitions and constructs that are all over the place, it's really hard to take it to the research to the next step. There's been some advances in the definitional guidelines. For instance, the Europeans have come up with a part 2 of their working definition for sarcopenia. The American contingent has come up with most recent guidelines last summer. They were published, and they actually importantly are noting the importance of grip strength over lean mass as a measure for sarcopenia. So the good news about that is can easily be measured even in clinical settings. What about in the real world? So a lot of the data that I presented you thus far has really demonstrated the rates and the prevalence rates and some of the associations of sarcopenia and sarcopenic obesity in cohort studies. Before I left Dartmouth, we had conducted a cross-sectional study in our weight management center that looked at the rates of sarcopenic obesity based on biological impedance analysis. So this is a way that we were able to capture body composition in these individuals. And what we found was that the rates actually increased with age, but we actually found that it was more prevalent in females than in males, and that it was less prevalent in Black or African Americans as compared to some of the other race or ethnic groups. And I noted that the definitions were all over the place. And this is actually really important because this study actually used different definitions of to look at the concordance of the definitions, and that they found that irrespective of the definition you used, and they compared the European definitions and the American definitions, and then the Asian definition as well of sarcopenia, and that they found that irrespective of age group, irrespective of the definitions used, the concordance was really poor. And even looking at sarcopenic obesity, that the rates were very low, for instance, using BMI. This is an Asian definition for sarcopenia, and I highlight the BMI not being your traditional BMI of over 30, and the reason for that is because the definitions in for obesity are different in that population. But what is important, putting my clinical hat on it, it's about physical function. And what was found was that only sarcopenic obesity using waist circumference as a measure of adiposity was associated with a measure called SPPB, which is the short performance physical battery. It's a marker of physical function. So that actually tells us something. Why? Because waist circumference is a surrogate for visceral fat, central fat, which is more pro-inflammatory. So that actually can play into the story as to when you have intramuscular fat deposition, that could lead to this cascade that could impair physical function. And what we know, this was an interesting analysis that demonstrated when individuals would gain visceral adiposity, central adiposity, they actually lose, it can lead to future loss of muscle mass. So when someone has central obesity, this could be a problem because they inadvertently affect the fat muscle interaction, so to speak. So you recall from my title that is the sum of the parts is greater than the whole. And I wanted to present you some data here that demonstrates this. And this is when we think about instrumental activities of daily living, this is the ability to go grocery shopping, do your checkbook, arrange your medications, for instance. And this study actually using the New Mexico aging process study found that there was almost a threefold higher risk of incident impairment in activities of daily living if you had both sarcopenia and obesity. We looked at this cross-sectionally using NHANES data and using the more recent definition of sarcopenia using the Foundation for the National Institute of Health. And again, we found different associations depending on the definitions. But what was consistent, both in males and females, that using these definitions, we noted a strong association of mobility limitations and sarcopenic obesity. Others have looked at this in different cohort studies: higher risk of knee osteoarthritis, higher risk of type 2 diabetes, higher risk of depression. So it not only affects muscle and fat, but it also it's thought to affect underlying insulin resistance and other mechanisms of disease as well. I always worry about falls. That's one thing that I am a big champion about. This is some submitted work that we actually found that using grip strength and both BMI and waist circumference, that individuals with sarcopenia actually had a higher risk of falls. But when you interplayed obesity using using BMI, it actually negated the association. And this was incident falls. I like to highlight that using the National Health and Aging Trends Survey. But importantly, using waist circumference, that there was a strong association. So I'm hoping that some of this data that I'm showing is that, with central adiposity and using waist circumference as a surrogate is actually really what's probably driving this association. This is an article that's soon to be published in JAMDA that, again, looked at the relationship between sarcopenia and sarcopenic obesity and incident cognition. The risk of incident cognitive impairment actually was higher in those with sarcopenia as compared to those with sarcopenic obesity. We hypothesized in this paper why, but there has been some literature that suggests that obesity may potentially be both a harm to cognitive impairment and protective. It's unclear why we saw these results. Again, further evaluations needed. But we know that the sum of the parts is worse than each of these individual parts themselves. This was, I believe, one of the first studies that looked at the risk of sarcopenic obesity the risk of death in sarcopenic obesity using NHANES data. We found sex-specific differences. Notably, we know that muscle mass and muscle strength are different by sex. But importantly here, that we used muscle mass in this analysis, and subsequent analyses that have used muscle strength have actually demonstrated significant impairments, a significant risk of mortality in both males and females. We'll skip that. So lastly, in this domain here, what I want to share with you is risk of death. And the risk of death really, we think, is worse, as I shared, with muscle strength and risk of sarcopenic obesity as compared to that of muscle mass. You can see that the risk of death was not significant in this meta-analysis, whereas the risk of muscle strength and obesity, irrespective of how obesity was defined, is there was a higher risk. And this is important, again, lending to the idea that muscle strength is likely worse and should be considered in the diagnosis of sarcopenic obesity. And when you think about physical function, you should be thinking about muscle strength over muscle mass. So some key points here, just from this section. There are long-term associations are strongly related to the definitions of sarcopenia and obesity. And the field needs to really move forward with regard to this. Muscle strength is likely a stronger predictor of decline than muscle mass. And the synergy of low muscle mass or strength and obesity is really associated with considerable morbidity and mortality. I'm going to shift focus a little bit and put my clinician hat on here. And again, this is a talk for another day, but I wanted to just present some data on the importance of obesity in older adults and thinking about how to intervene. There's a dearth of data really evaluating this entity and this group. We did a systematic review a number of years ago, and what we found is that combined diet and aerobic and resistant exercises led to improvements in physical performance, quality of life, more so than either separately. The importance of physical activity cannot be understated. This was a seminal trial, the LIFE study. If you haven't read it, this is key to mitigation of mobility disability. Individuals in the intervention arm and the intervention arm consisted of walking 150 minutes per week and doing a home exercise program of strength, flexibility, and balance. These individuals actually had a reduction in major mobility disability and persistent mobility disability over time. So this tells you that irrespective of where you are in your disease trajectory, the mean age in the study were 79 years. These are sedentary older adults, as compared to a health education arm. So a clinician just saying, here are some materials, go home and follow them. We found that there was a marked reduction in major mobility disability and persistent mobility disability. This is key, because when we think about geriatrics, we think about physical function, and we think about disability, and we think about nursing home placement. There are some studies that have come out, secondary analyses, that have demonstrated persistence in the effect size between the two groups. So this works, and when you put this together, this is I present this as a seminal geriatric obesity trial. So Dennis Villarreal, who's now at Baylor, looked at the impact of a control group, usual care, an aerobic exercise, resistant exercise, and a combination of diet and aerobic and resistant exercise group. Notably, he only had 40 participants in each arm, but he was powered to look at differences in the physical performance test. Individuals who had any type of dietary intervention lost weight. Those, in a separate study, those with just engaging in aerobic or resistant exercises did not lose weight. But the combined aerobic and resistant exercise plus diet led to synergistic improvements of physical function from baseline. And these were individuals who were classified as being frail, and who in an ancillary study were found to have a considerable degree of sarcopenic obesity, and had low muscle strength, low muscle mass, and the like. So these are weight loss interventions are safe and effective, and importantly can improve physical function in older adults. I just wanted to share one slide here on a recent study that's just got published, and we're preparing. We have another study that's in the pipeline. This is our telemedicine-based study. Penny mentioned that some of the work that I've done has been in telemedicine delivery of weight loss interventions. This is a pilot study that we conducted right before I transitioned here to UNC. And we found some decent weight loss of 4.7%. It was a 6-month intervention of a dietitian and physical therapy based weight loss intervention. But what I want to bring to your attention is we saw significant improvements in 30-second sit to stand. Clinically significant is two repetitions, and a marked improvement in 6-minute walk of 42 meters. We also saw subjective improvements in late life physical function. And importantly, while we saw reductions in body fat, we saw marked reductions in visceral fat, but we did not see any changes in appendicular lean mass. Why is that important? Because when you lose when you lose weight, for the old adage is you lose 1 kilogram of weight, you're losing 75% fat, 25% muscle. And we worry when you lose muscle mass, that could be potentially detrimental to physical function. I didn't present this here, but we actually set stability, and I believe we saw some mild improvements, non-significant improvements in grip strength. So despite losing weight, there was stability of lean mass and stability of grip strength, which suggests that you're reaping the rewards of improved physical function and not impacting one's musculoskeletal system. Last few slides here, I wanted to raise to your attention that this is the group at Wake actually conducted a systematic review of all RCTs that they had conducted in older adults with obesity. And what they found, and it just approached significance of a 15% reduction in mortality. Their mean follow-up was short, was 27 months, as you can see, but it does give some indication is not only can it improve weight loss in older adults can improve physical function, but it also can potentially reduce risk of death. So I come back full circle to the life course. Why do I do this? Because this is something that's really important when you think about weight cycling. And weight cycling is the phenomenon where individuals lose weight, gain weight, lose weight, gain weight, and they've classified this accordingly. But you can see that individuals from a life course standpoint who have weight cycled actually have a higher risk of death. So that is a problem, and that, you know, and this is where, in my mind, and kind of digressing a bit, is this where you can think about informatics-based approaches to be able to look at life cycle, life course-based evaluations of one's weight to be able to identify these individuals and potentially that they may need different targeted interventions. So some key points. Weight loss interventions can improve physical function in older adults. Weight cycling can potentially be dangerous. And safety really of weight loss is of paramount importance in older adults. I didn't get into this data, but I'm a firm believer in the importance of coordination with their primary care doctor. And when you lose weight, a lot of these patients have a number of chronic conditions or a lot of medications. Their blood pressure can drop, their diabetes can improve, and if they're on medications for diabetes, that could be a problem. I give the example in one of our weight loss interventions, we had to, someone went hypoglycemic on us, and we, you know, thankfully we were able to coordinate with their PCP and have that adjusted because of the resultant weight loss that they've had. So where does this field need to go in the future? I am a firm believer that standardized definitions are critical in advancing the field. You cannot look at associations both either cross-sectionally or longitudinally without standardized definitions. And these standardized definitions, I think there's been progress in the last decade, but unfortunately we're not quite there yet. There are major gaps in our understanding in socio-demographic determinants in midlife that can impact the development of sarcopenic obesity. And that's an area where I really feel that there's the research is wide open to tap into. Evidence-based interventions are needed, really to target these biological mechanisms, both in clinical and research settings. Physical functioning needs to be evaluated as an outcome. Older adults, in my experience, while they're worried about death, are more worried about a need for institutionalization. They don't want to be institutionalized in a nursing home. And one thing that I've really appreciated more and more, both in my career, but also now transitioning here, is the importance of heterogeneity, both clinical and statistical, because not everyone is the same. And a one-size-fits-all strategy is problematic, particularly in older adults who have a considerable amount of clinical heterogeneity. And with that, I want to thank you for your time, and I hope and I'd be more than welcome to entertain any questions going forward. Thank you.
Wonderful. That was fantastic. Really enjoyed you bringing the life course perspective and you know, bringing awareness to a lot of these really critical issues. There is one question in the question and answer, and if folks want to go ahead and let us know, I am going to just ask the first quick question, hopefully. Would you speak at all about, you know, in terms of heterogeneity, SES, race, ethnicity, and how some of those differences play into some of these issues?
And that's a $1 million question in some ways, Penny. So there's a heterogeneity of aging in itself. And a lot of these life course factors, you know, all these factors that you just explained can impact one's physical function downstream and impact the trajectories of aging. And we know that they are impacted. How they're impacted is what is a key question. And how do you intervene, importantly, on those factors is anybody's guess. The issue of, I imagine you're alluding to the issue of precision medicine in this population. And there was a great, I would strongly recommend Luigi Ferrucci and George Kuschel published an editorial in Journal of American Geriatric Society on clinical heterogeneity of aging. I think it was in January. Unbelievable article, both from identifying and not understanding some of these factors and how it modifies these trajectories of physical function. Because really, you need to be able to intervene early on. And once they arrive to me in the clinic, you have problems. And while that doesn't mean you can't treat and you can't address them, you're behind the 8 ball at that point.
Yeah, thank you. Well, I think Elizabeth has a question.
John, that was fabulous. Thank you so much. I am curious. So, we're starting a number of field-based longitudinal surveys. They're sort of underway at CPC, but new waves are starting. And if you sort of thought about like the top 4 to 7 physical assessments / biomarkers that you would put in to capture these dynamics, in places like not only the US, but China and Asia as well, the Philippines, what are the things that you would emphasize?
That's a great question. And I'm so glad you brought that up, because that's, for me, this is my passion, is physical function assessment and measures in some ways, and how you integrate it in not only these surveys, but intervention studies as well. So you need to make them simple. And that's one of the challenges when in the utopian world, I would love to get body composition on everybody, but guess what? That's not going to be practical in many of these cohort studies unless there's a significant amount of funding. So keeping it simple, as I shared, waist circumference, easily done. And functional measures, gait speed, cheap, easy to do, quick. Grip strength, it's a handheld dynamometer, very easy to do. 6-minute walk, maybe a little bit trickier. You need to have trained, and a lot of it is IRB dependent in terms of a safety standpoint. But there are other measures, sit to stand test. There's both a 5-time sit to stand and a 30-second sit to stand. These are very cost-effective physical function measures with excellent predictability for incident disability downstream.
Great, thanks. That is super helpful. And I may offline contact you about some of the measures we've been using and see if we can improve them.
Most happy to.
Super. So the question from the audience here, how much does weight need to swing in terms of the magnitude of weight change to move from mundane fluctuation to weight cycling?
Great question. I would say that one of the challenges, and when we look at weight cycling in epi studies, is it's defined in, if you think of it's defined in 10 different ways, it's probably defined in 20 different ways. So I don't have a good answer to your question, but what I can say is that we, in some of these studies, that I believe the study that I presented here, it was looking at gain and loss of 5% over I believe it was a 2 to 3 year period of time. And I have to double check on that. But that is the $1 million question. We don't know. We know that changes in trajectory, linearly in the same direction could, are associated with adverse outcomes, particularly if you are classified as having obesity. But if you're losing 10%, gaining 10%, losing 10%, that's a problem. Because what also transpires, and something I didn't really dive deep into this, is when you gain weight, if you're not concurrently conducting resistance-based exercises, you are likely to gain more fat than muscle. And that becomes even more of an issue from a sarcopenia standpoint.
Super. Well, we are at the hour. I have to leave, but John kindly said that he would stick around if anybody has more questions for him. So I'm going to bow out. I think they're going to stop recording, and I'll just let you all have a conversation. But thank you again so much. This was really fascinating. Amazing to have your expertise here and to learn all about all of these really critical issues. So thank you so much. We really appreciate it.
I appreciate the invitation, Penny. Thanks.